Good afternoon, and welcome to the Current Issues in Immunization Net Conference Series. I'm Joellen Walicki. I'm a nurse educator in the Immunization Services Division of the National Center for Immunization and Respiratory Diseases, or NCIRD, here at CDC, and I'll be the moderator for today's session. To participate in today's program, all you will need is an internet connection. Today is Wednesday, June 15th, 2016, and Dr. Raymond Strickis, Medical Officer in the Communication and Education Branch of Immunization Services Division in NCIRD CDC, will discuss General Recommendations Part 2 and vaccine safety as presented in the CDC textbook, Epidemiology and Prevention of Vaccine Preventable Diseases, also known as the Pink Book, whose 13th edition was published last year. At the conclusion of this session, the participant will be able to describe the different forms of immunity, describe the different types of vaccines for each vaccine preventable disease, identify those for whom routine immunization is recommended for each vaccine preventable disease, describe characteristics of the vaccine used to prevent the disease, describe an emerging immunization issue, locate resources relevant to current immunization practice, and implement disease detection and prevention healthcare services, for example, smoking cessation, weight reduction, diabetes screening, blood pressure screening, and immunization services to prevent health problems and maintain health. Continuing education, or CE credit, is available only through the CDC ATSDR Training and Continuing Education Online System at www.cdc.gov/TCEonline/. If you are watching this version live, CE credit for the session will expire on July 18th, 2016. If you are watching the Enduring Archive version, CE credit for the session expires on June 1st, 2018. When obtaining CE, you will be required to provide a verification code. Watch and listen for the verification code during the course. Verification codes will not be given outside this presentation. CDC, our planners, and our presenters wish to disclose they have no financial interest or other relationships with the manufacturer of commercial products, suppliers of commercial services, or commercial supporters. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC does not accept any commercial support. A list of resources will be available for General Recommendations Part 2 and Vaccine Safety on the web, and the webpage is www.cdc.gov/vaccines/ed/pinkbook/pb1.asp. If you have a question during this presentation, please type your question into the Q&A pod, which is a space at the upper right-hand corner of your screen. I will collect these questions during the presentation, and then we will address them during the question-answer period, which will follow Dr. Strickis' presentation. I will now turn the microphone over to Dr. Strickis. You may begin.
Thank you, Ms. Walicki. Today's presentation covers two topics. The first is General Recommendations Immunization Part 2, and the second is Vaccination Safety. The flow of my presentation will correspond to the latter part of the second chapter of the 13th edition of Epidemiology and Prevention of Vaccine Preventable Diseases, or the Pink Book, beginning on page 28. I'm then going to discuss the topic of invalid vaccine contraindications, a topic that is discussed in both the general recommendations and the vaccine safety chapters. Following that, I'll discuss the vaccine safety chapter, which is chapter 4 of the Pink Book. The slides I'm using are similar to the graphics you see in the margins of the Pink Book, and I'll be posting these slides in the near future. To recap a bit from last week's presentation, the term or concept General Recommendations on Immunization refers to those recommendations that apply to all vaccines. CDC guidance often comes in the form of a single vaccine-specific recommendation or set of recommendations, but in practice you have to deal with 15 vaccines given routinely to patients depending on age. The general recommendations are a canon of guidance to address situations commonly encountered in vaccine practice and essentially applicable to all, if not or most, vaccines. CDC publishes this guidance in a Morbidity and Mortality Weekly Report in the Recommendations and Reports series. Since the original publication of the General Recommendations in 1976, there have been 8 revisions, the last in 2011, pictured here. This document is 62 pages with 239 references. We anticipate posting another revision to this guidance later this year. CDC generates this guidance based on the deliberations of the Advisory Committee on Immunization Practices, or ACIP, a non-governmental advisory group of 15 members that meets 3 times a year in Atlanta and makes recommendations to CDC. So this MMWR is considered not only CDC guidance, but ACIP recommendations. Last week, Dr. Kroger concluded his presentation with a discussion of contraindications and precautions. Contraindications are conditions in a vaccine recipient that should cause you to withhold a dose of vaccine. Precautions are conditions in a vaccine recipient that may cause you to withhold a dose of vaccine, and those conditions may be permanent or temporary. Today I'll begin with a discussion of screening as the best way to identify contraindications and precautions. Screening questions are specific questions used to identify contraindications and precautions. Some conditions are temporal, so they not only come and go, but they can come again or recur. Therefore, you must screen at every immunization encounter, not just before the first dose of a series. Pregnancy is such a condition. A standardized form can be used so screening can be done effectively. As I go through the questions, this will provide an important recap of the most important contraindications and precautions that Dr. Kroger described in detail last week. The following questions are written from the perspective of a pediatric visit, but the questions can be adjusted for an adult patient population. The first basic question is the child or the patient sick today? This identifies acute, severe, or moderate illness, which is a precaution for all vaccines. A common question that is part of every health encounter. Does the child have an allergy to any medications, food, or any vaccine? So with this question, the most common allergens are identified by the patient or the parent or guardian, and then can be cross-checked against lists of vaccine components. This is an acceptable way to proceed because the type of allergy we are looking for, that is severe anaphylactic allergic reactions, is the specific contraindication, and these events are extremely rare. You might then ask, or should ask, has the child had a serious reaction to a vaccine in the past? Which, besides identifying anaphylactic allergy, the question may pick up past cases of encephalopathy following pertussis-containing vaccines, which are contraindications if not otherwise identified, and which if they occurred within 7 days of a pertussis-containing vaccine, or past cases of fever, seizure, or limp episodes or uncontrollable crying for 3 hours straight following pertussis vaccine, and these are precautions to further doses of pertussis-containing vaccines in children. You might then ask, has the child had a seizure, brain, or nerve problem? And these would also identify encephalopathy and/or seizures, again relevant to pertussis-containing vaccines. Has the child had a health problem with asthma, lung disease, heart disease, kidney disease, a metabolic disease such as diabetes, or a blood disorder? Children with these conditions have a precaution for live attenuated influenza vaccine. They should receive an activated influenza vaccine instead unless you are comfortable giving them live vaccine. On the other hand, children with these chronic health conditions may be candidates for other vaccines, such as pneumococcal polysaccharide vaccine. Ask, does the child have cancer, leukemia, AIDS, or any other immune system problem? This will identify a history of immunosuppression or current immunosuppression, which is a general contraindication to live vaccines. Likewise, has the child taken cortisone, prednisone, other steroids, or anti-cancer medications, or had X-ray treatments in the past 3 months? This would help you find a history of immunosuppressive therapy, for example, with the medications or treatments I just asked about, and this would also be considered immunosuppression and, again, a contraindication to live vaccines. Note that I've listed a 3-month period or washout period for some of these treatments, like 3-month treatment washout period, but for some treatments, like low-dose steroids or low-dose methotrexate, a 1-month interval may be appropriate. For initial screening, it makes sense to be conservative and think in terms of 3 months. Has the child received a transfusion of blood or blood products, or been given a medicine called immune or gamma globulin in the past year? This question is relevant from both a safety perspective and cover potential chronic disease or immunosuppression, but also to differentiate the interval you need to wait from some of these medications to MMR and varicella vaccine, which can be as long as 11 months because of concerns about the effectiveness of the vaccine if given too soon after that immune or gamma globulin. Also ask, is the child or teen pregnant, or is there a chance she or you, the patient, could become pregnant during the next month? Pregnancy is a general contraindication to live vaccines, and the period after live vaccines for which we recommend avoiding conception is 1 month. Ask if the child has received vaccinations in the past 4 weeks. This identifies a recent history of live vaccines, which requires a 4-week interval for non-simultaneous vaccination. Note there are also intervals between 2 brands of inactivated pneumococcal vaccines, that is 8 weeks between pneumococcal conjugate vaccine, or PCV13, and pneumococcal polysaccharide vaccine, or PPSV23, as well as a 4-week interval required between PCV13 and the Menactra brand of meningococcal conjugate vaccine, or MCV4. These screening questions are available as a formatted tool courtesy of the Immunization Action Coalition and available at their website at www.immunize.org. That is www.immunize.org. I'm sorry I didn't get this on the slides, but you can write it down as immunize.org. I'm now going to discuss invalid contraindications. These are conditions that are often misunderstood by providers as a reason to withhold a dose of vaccine. Since these are not true contraindications or precautions, if a dose is withheld, it reflects a missed opportunity for vaccination. I've mentioned that moderate or severe acute illness is a precaution to vaccination. However, many providers misinterpret that to mean that vaccine should only be given to completely healthy persons at well visits. This is not true. Studies have looked at vaccination of persons with low-grade fever, upper respiratory infection, otitis media, and mild diarrhea, and in all of these cases, there was no additional safety concern or problem when the vaccines were administered. That is why we sometimes describe mild illness as an invalid contraindication. You should vaccinate given these circumstances so as not to miss an opportunity to vaccinate and protect your patient. Another circumstance that often confuses providers is the vaccination of household contacts of pregnant women. Household contacts should receive MMR and varicella vaccines, and they should receive either non-live influenza vaccine or the live attenuated vaccine, LAIV. While zoster vaccine and rotavirus vaccine are given at the extremes of life, so a patient in these age ranges are less likely to be in contact with a pregnant woman, if there are circumstances such that a household contact is eligible for zoster or rotavirus vaccine, the vaccine should be administered. The benefit of protecting a pregnant woman from all the complications of any vaccine-preventable diseases by vaccinating their household contacts outweighs any risk from a live vaccine microbe. The risk of live vaccine virus transmission is close to zero, with the exception of varicella vaccine. And even though varicella disease can affect the fetus, varicella vaccine viruses have not been shown to injure a fetus, and in most circumstances, the mom is already immune from varicella. Another invalid contraindication is preterm birth, that is less than 37 weeks gestational age. Generally, infants and children should be vaccinated according to chronologic age, with no need to account for the gestational age. Full doses of vaccine are recommended. Birth weight and size are not a factor. The one exception to this is hepatitis B vaccine, which is recommended at birth. If the preterm infant weighs less than 2,000 grams and has a mother who is hepatitis B surface antigen negative, then a dose of hepatitis B vaccine can be delayed until discharge from the hospital or chronologic age of 1 month. This is a concern about proper vaccine effectiveness and maximizing the response of the dose of the vaccine in this preterm infant. However, note that if mother's hepatitis B status is unknown or is positive for surface antigen, this exception goes out the window and vaccination must occur at birth, the recommended time, to provide optimal protection for potential hepatitis B disease exposure. Now I begin a discussion of vaccine safety and its assessment. If you're following along in the Pink Book, you should jump ahead one chapter to Chapter 4. I'm going to divide my comments into some general principles about why vaccine safety is an important topic, how CDC monitors vaccine safety, and the role that providers can play in ensuring vaccine safety. As far as the provider's role, you've already heard about screening, but I'll elaborate and discuss some principles of risk-benefit communication. Let's begin with a discussion of why vaccine safety is such an important topic. This table lists the average annual morbidity in the 20th century for a variety of vaccine-prone diseases, and the 20th century annual morbidity in the second column was calculated from data available in 2007, and then there's a list in the third column of data from 2014 for these same diseases in terms of their frequency of cases in 2014. In the right-hand columns displayed the percentage increase in disease morbidity. The table that is in your Pink Book safety chapter has slightly different numbers because the current year is 2006 instead of 2014, and also the comparison morbidity data from the 20th century is not an average over the entire period of time, but reflects data collected from a point in time prior to the 2007 data listed on this slide. The important message here is that the right-hand column marks this data as a success story for vaccines, with marked reduction in reported cases of all the diseases, mostly over 90 to 99% or even 100% in some cases, with the exception of pertussis, which has not been reduced as much as we would like. Look at the bottom row of the table, which lists the average number of adverse events reported to the Vaccine Adverse Event Reporting System, around 30,000 per year. Looking at the reported cases column for 2014, note this number is over 34,000 cases and therefore similar to the number of adverse events reported to CDC and FDA in the Vaccine Adverse Events Reporting System. Providers and parents may be more likely to see a clinical outcome and report this as an adverse event than they are to see a vaccine-preventable disease in many cases. Because vaccines are universally recommended or mandated, they are given to large numbers of people. We can anticipate a lot of reporting of adverse events. We also realize safety problems that might exist with vaccines have the potential to affect a large number of people. Ongoing safety monitoring is needed for the development of sound policies and recommendations. Public health constantly weighs the burden the disease places on our population, which argues for continued use of a vaccine against any new vaccine risks that might be identified with large numbers of people receiving the vaccine. Now, certain vaccines have been discontinued, like smallpox vaccine and oral poliovirus vaccine, when the disease has become very uncommon or eliminated, and it was determined the risk from the vaccine outweighed the benefit. As I showed in the first safety slide, as a disease risk, let me go back to where I belong. As disease risk decreases, the concern about vaccine risk increases. Many providers and patients have never seen a case of Haemophilus influenza type B meningitis or epiglottitis, or have never seen measles. Because of this disease reduction, public confidence in vaccine safety is critical. When I use the word public, I'm speaking broadly to include both patients and you, the healthcare providers. A higher standard of safety is expected of vaccines compared to other medications because vaccines are administered generally to people who are healthy as opposed to persons who are ill and need therapeutic medications. And because we're less tolerant of vaccine risk, we continue looking for rare reactions even post-licensure, and there are tools that allow us to do this. Lastly, the fact that vaccines are universally recommended and sometimes mandated means that there's even less tolerance for vaccine risk on a population basis because vaccine safety concerns affect all of us. From a communication perspective, it is important to state we are not defining as safe as no harm at all from the vaccine because no vaccine is 100% safe. It is also misleading to say that vaccines will make someone 100% safe from the disease because there is no vaccine that is 100% effective in preventing disease. But years are required to develop vaccines through research, development, and production, and create products that are as close to zero risk as possible from the outcomes of vaccines and come close to 100% effective in preventing severe complications of vaccines. Vaccines companies have estimated it takes between 8 and 12 years to produce vaccines and bring them to market. Parents should be reminded that until a disease is eradicated, there is risk of disease-based complications, and to avoid a dose of vaccine also involves taking a risk. Like other pharmaceutical products, vaccines undergo extensive laboratory studies to understand the mechanism of action which has safety and efficacy implications. Vaccines are then studied in animals, and attempts at safety and efficacy comparisons are made in humans, always erring on the side of safety for humans when it comes to the volume of the dosage given to smaller animals. Finally, extensive phase studies are carried out in humans. Phase trials in humans are divided into 3 stages or types, 1, 2, and 3. Phase 1 human clinical trials usually involve anywhere from 20 to 100 volunteers and focus on detecting serious side effects and determine a safe dosage range. Phase 2 trials generally enroll hundreds of volunteers and may last a few months to a few years. Safety is still an important focus, but now the tests are looking at how the human immune system responds to the vaccine. These trials determine the most effective use of the vaccine, the best dose for effectiveness and safety, and the correct number of doses. Phase 3 trials involve a few hundred to several thousand volunteers and may last several years. Phase 3 trials usually include a control group who receive either a placebo or another already licensed vaccine, allowing researchers to compare one vaccine to another or to a placebo for adverse health effects and also to calculate vaccine efficacy. Most Phase 3 trials include 2,000 to 5,000 participants and sometimes more. The largest Phase 3 trial in the last several years was the rotavirus efficacy and safety trial, often abbreviated as REST, R-E-S-T, which included about 70,000 infants. The trial needed to be this large in order to assess for a relatively uncommon possible adverse event, intussusception or telescoping of bowel leading to bowel obstruction in infants. The trial determined that intussusception was no more common in vaccine recipients than among placebo recipients. If the vaccine is shown to be safe and effective in Phase 3 trials, the manufacturer will usually apply for a license from the Food and Drug Administration, or FDA. During the application process, the FDA reviews everything: the clinical trial results, product labeling, the manufacturing plant, and the manufacturing protocols. However, while rates of common vaccine reactions, such as injection site reactions and fever, can be estimated before licensure, the comparatively small number of patients enrolled in these trials generally limit detection of rare side effects that occur perhaps 1 in 100,000 or less often, side effects that may occur many months after the vaccine is given, and side effects that may occur in certain subpopulations, such as varying age groups. Therefore, it is essential to monitor reports of vaccine-associated adverse events once the vaccine has been licensed and released for public use, and this is part of post-licensure surveillance. In addition to identifying these rare reactions, post-licensure safety surveillance can monitor increases in known reactions and, more importantly, identify certain risk factors that may contribute to the adverse reactions. Sometimes the FDA requires Phase 4 studies, which are done by vaccine manufacturers after the drug or treatment has been marketed and licensed, to gather information on the drug or vaccine's effect in various populations and any side effects associated with long-term use. These studies and other post-licensure safety surveillance also collect programmatic information like lot numbers and can identify if increased adverse reaction rates are associated with specific lots of the medication or vaccine. Last but not least, our post-licensure surveillance can identify signals, that is, reports of adverse events more numerous than would be expected, usually looking across all vaccines, and thereby identify reactions that no one has considered previously. This is how new adverse reactions are discovered. The Vaccine Adverse Events Reporting System, or VAERS, we commonly abbreviate it to the word VAERS, was created in 1990 and is jointly administered by the CDC and the FDA. It is a national passive reporting system to collect all reports of clinically significant adverse events reported by manufacturers, healthcare workers, and the general public. VAERS receives about 30,000 reports per year, and to date, since 1990, has over 130,000 reports in the database. Though this seems like a large number, it is relatively small compared to the 100 million doses of childhood vaccines distributed during the past decade, as well as millions of additional doses given to adults, such as the 100 million or more doses of annual influenza vaccines administered. The VAERS program is a tool which seeks to capture all clinically significant medical events occurring post-vaccination, even if the reporter is not certain that the incident is vaccine-related. Despite some limitations, VAERS has been able to fulfill its primary purpose of detecting new and/or rare vaccine adverse events, increases in rates of known side effects, and patient risk factors for particular types of adverse events. For example, VAERS tracked and raised the concern about intussusception after the first rotavirus vaccine, RotaShield, in the 1990s, and anaphylactic reactions to MMR vaccine caused by gelatin allergy, a component of MMR vaccine. Additional studies are always required to confirm signals detected by VAERS because not all reported events are causally related to vaccine. Simply because a health problem occurred after vaccination does not mean that vaccination caused the health problem. The reportable events table in Pink Book Appendix D as in David 2 lists what is reportable by law to VAERS, including conditions found in the manufacturer's package insert. In addition, healthcare professionals are encouraged to report any clinically significant or unexpected events, even if you're not certain the vaccine caused the event, for any vaccine, whether or not it's listed on the reportable events table. Manufacturers are also required by regulation to report to VAERS all adverse events made known to them for any vaccine. A reminder to you that just because something is reported to VAERS, or we suggest you report something to VAERS, doesn't mean that this event was caused by the vaccine. The Latin dictum post hoc ergo propter hoc, translated after this, therefore because of this, is known as an ecologic fallacy. A fallacy because temporal association does not prove causation. Causation must be determined after two occurrences have been studied statistically, and even then we call this an association or correlation, not causation. Think about how coincidences happen, such as someone could have a car accident on the way home from the vaccination clinic, even if he or she was otherwise doing well, and that does not mean that the vaccine dose caused the accident. Coincidence is a real phenomenon. Causation requires at least answers to 5 questions. Is the diagnosis of the adverse event correct? Does clinical or laboratory evidence exist that supports possible causes for the event other than the vaccine in the affected individual? Is there a known causal association between the event and the vaccine? Is there strong evidence against a causal association? Is there a specific laboratory test implicating the vaccine in the pathogenesis of the event? Now, if there's determined to be correlation between vaccine and outcome, then additional concepts can be explored, and we try to look for the answers to the questions I just listed to determine causation, like duration of time between the exposure and the event, whether it's been seen before, whether it can be shown to occur again, and whether there is a biologic mechanism or plausible association or laboratory quantification of a dose response. So let's explore some of the ways we evaluate adverse events. To access correlation of a vaccine with an outcome, 4 pieces of information are needed at a minimum. Among persons who receive the vaccine, you must know how many cases of the event of interest occurred on this table marked by some number that belongs in cell letter A, and how many vaccinated persons did not develop the event on this table marked by cell B. You also need to know the background rate of the event of interest. You determine this number by identifying an unvaccinated group of people and determining the number of persons who did and did not have the event of interest. This would correspond to cells C and D respectively. So these four pieces of data allow you to calculate the rate of the event among the vaccinated group, which is A divided by the sum of A plus B, and the background rate of the event in the unvaccinated population, or the number C divided by the sum of C plus D. If the rate in the vaccinated group is higher than the rate in the unvaccinated group, and other factors have been properly controlled for, such as age and health conditions, then the vaccine may be correlated to the outcome, and further study can be pursued. Unfortunately, the VAERS system only provides one of these four important pieces of information, that is cell A, the number of events that occur in a population of vaccinated persons. That is why VAERS data cannot be used alone to assess whether or not a vaccine is correlated to an event. Many events have been reported among vaccinated persons and constitute a signal, and so additional studies are needed to get the data for all cells to evaluate correlation. This slide is an example of such a study. These are actual data published in a 2002 New England Journal of Medicine paper that looked at autism spectrum disorder, or ASD, among persons who received MMR vaccine and persons who did and did not receive MMR vaccine. These are children in Denmark between 1991 through 1998. The vaccine row shows that of those who received the vaccine, 345 people had ASD, and 440,310 people did not have the disorder. Notice how important cell B is to this figure. It looks like 345 is a large number of cases, but not when you realize how many people were vaccinated without experiencing this outcome. Now look at the bottom row. Looking at those persons who did not receive vaccine, 77 had ASD, and over 96,000 did not. Note that the total number of people in the no vaccine row or bottom row is much smaller than the vaccinated row. Denmark has very good coverage with MMR vaccine, and therefore 345 doesn't look very large, stacking up to the 400,000 people who received vaccine did not have ASD. So we calculate the fractions A over A plus B and C over C plus D and simplify the fractions with a common denominator of 10,000. You see the overall rate of ASD in those who received the vaccine compared to those who did not receive the vaccine was 7.83 versus 7.96. The relative risk is 0.98. There's no statistical difference between these two rates, meaning there was no correlation in this study between autism spectrum disorder and MMR vaccination. This slide brings me to other post-licensure evaluations, which include the Phase 4 studies we discussed earlier that are conducted by manufacturers and usually do include tens of thousands of volunteers and can be used to address questions of long-term effectiveness and safety or examine unanswered questions identified in Phase 3 studies. Other post-licensure studies include the Vaccine Safety Data Link, which is an example of a large link database, one of CDC's tools I'll talk about in a moment, or the Clinical Immunization Safety Assessment Project, which I'll also describe. CDC is a partner on these. Now, the Vaccine Safety Data Link is a large link database, commonly abbreviated LLDB, which means it connects computerized pharmacy prescriptions and immunization records with computerized medical records. These databases are derived from defined populations such as members of managed care organizations or HMOs, single provider healthcare systems, and Medicaid programs. Data are usually generated in the routine administration of these programs, and these databases do not require the completion of a vaccine adverse event reporting form, therefore reducing the problems of an underreporting or recall bias. The populations are under active surveillance rather than passive surveillance. All their data are recorded in their medical records, and this allows for establishment of causal relationships and timely analysis. The Vaccine Safety Data Link, or VSD, links the immunization and medical records for members of 9 HMOs totaling more than 3% of the U.S. population, or about 10 million people. In partnership with CDC, these programs plan and execute immunization safety studies investigating hypotheses from medical literature, VAERS reports, and changes in the immunization schedule or introduction of new vaccines. The Clinical Immunization Safety Assessment, or CISA or CISA network, was established in 2001 as a network of 7 centers with vaccine safety experience in partnership with the CDC. This network is designed to improve the understanding of vaccine safety issues at the individual level. The network of coordinated facilities investigates and manages vaccine side effects for individuals for the purposes of providing patient care. It also systematically collects and evaluates data on these experiences to gain a better understanding of how such events might occur and develop protocols or guidelines for healthcare providers to help them manage similar situations in their practice settings. CISA also conducts studies that identify risk factors and has contributed to the development of ACIP recommendations. So that's a summary of the systems we have in place to try to assure vaccine safety and to monitor for adverse events. But we know that in spite of these efforts, some rare adverse events occur that are caused by vaccines. So what happens then? Well, that's where the Vaccine Injury Compensation Program comes in. During the mid-1970s, lawsuits concerning vaccine adverse events were being filed against vaccine manufacturers, resulting in legal decisions and damages awarded, despite limited scientific evidence to support the claims. As a result of these liability claims, vaccine prices soared and several manufacturers stopped or considered stopping vaccine production. Vaccine shortage, particularly of diphtheria, tetanus, and pertussis vaccine, resulted, and there was concern about the return of epidemic disease. This situation led to the National Childhood Vaccine Injury Act of 1986, which in turn established the Vaccine Injury Compensation Program. This program is intended to compensate individuals who experience certain health events following vaccination on a no-fault basis, meaning the plaintiffs are not required to prove negligence to receive compensation. The program covers all routinely recommended childhood vaccines. Settlements are based on a vaccine injury table, which is located in the appendix of the Pink Book on pages D5 and D6. The table lists and explains injuries and conditions that are presumed to be caused by vaccines. It also lists time periods in which the first symptom of these injuries or conditions must occur after receiving the vaccine. So we've now talked about the processes to ensure vaccine safety and the process to compensate for rare cases of injury. Now I'd like to return to the provider's role, that is your role, in ensuring vaccine safety. With the aforementioned projects in place to monitor safety, the provider has additional roles in ensuring vaccine safety by storing and handling vaccines correctly, scheduling vaccination at appropriate times, screening for contraindications and precautions, managing adverse events after vaccination, reporting these adverse events to VAERS, and communicating effectively the benefits and risks of vaccinating. Storage of vaccines and administration of vaccines will be discussed in future programs in this series. We've already discussed timing and spacing and screening for contraindications and precautions. For management of adverse reactions at a minimum, providers should have epinephrine and equipment to maintain an airway to manage anaphylaxis, which many of you probably will not see because it occurs on an average of about 1 case per 1 million doses of vaccine administered. However, your office should have an emergency plan and providers should be certified in cardiopulmonary resuscitation. I've already discussed reporting to VAERS, so let's focus on the last item on this list, benefit and risk communication. Before each vaccination, providers need to inform parents, guardians, and legal representatives of the benefits and risks of the vaccine or vaccines in language they'll understand. Opportunities for questions should be provided before each vaccination. The National Childhood Vaccine Injury Act requires the use of vaccine information statements, or VIS, which must be given before each dose of vaccine if the vaccine in question is routinely administered to a recommended age group encompassing 0 through 18 years, which is most vaccines in use today. This is a requirement for both public sector and private sector providers. The VIS are available in English on the CDC website and are available in multiple other languages. To obtain VIS in other languages, please visit the Immunization Action Coalition's website at www.immunize.org. It'd be great simple that the legal VIS addressed every possible question that a patient or parent may have. However, you as a provider have to anticipate other types of questions and concerns of parents, given the type of population you're dealing with, and realize that parents are being flooded with information on the internet and from many other sources as well. Celebrities often claim to be health advocates based on personal experience, not science, such as Jennifer McCarthy when she claimed that her son's condition was due to vaccine. She did not have science to back her up on this, but her words carried weight because she was well known. Public health has looked to other celebrities who advocate for vaccination, and their efforts have been helpful. Amanda Peet, Jennifer Lopez, and Campbell Brown have all discussed the importance of vaccination, primarily in the context of pertussis and measles outbreaks, which have resulted in part from vaccine hesitancy and low vaccination rates in some communities. The efforts are helpful, but as a provider, your recommendations have even more power. Studies show that if a provider makes a recommendation, parents are more likely to have their children vaccinated. When parents express a concern, ask questions so you fully understand what the concerns are. Acknowledge that the parent has the concern, and then provide advice. Starting interactions at the prenatal visit is important as continuity of care helps establish trust in you as the provider. You also need to be aware that resources are available in a wide variety of sources from CDC and others, and know the science behind parent concerns. Try to find common ground with the most resistant parents and accept that you may not get a parent to accept all vaccines. And while you must document vaccine refusal, you should not remove patients from your practice for doing so. As far as the science around the concern of autism, I've already discussed one study from Denmark and the epidemiology supporting no association between MMR and autism. There are other studies that have been conducted, all to successfully counter the claims that MMR or preservative thimerosal are associated with autism. This is a partial list of representative studies looking at both the MMR and thimerosal issue. Once enough of these studies became published, the tide started to turn in favor of science, and later autism advocacy organizations like Autism Speaks began to reach the same conclusion that autism is not associated with vaccination. Autism advocacy organizations then began to speak out in favor of the science. The spokesperson for Autism Speaks, Dr. Jerry Dawson, stated in 2009 that given what the scientific literature tells us today, there is no evidence that thimerosal or the MMR vaccine causes autism. Evidence does not support the theory that vaccines are causing an autism epidemic. Another organization also helped tremendously to communicate that we all have a shared goal in finding the true cause of autism, that it is time to stop expending efforts on theories that MMR and thimerosal have a role in this disease. In 2011, the Health Resources and Services Administration asked the Institute of Medicine, or IOM, part of the National Academy of Sciences, to review a list of adverse events associated with 8 vaccines: varicella, influenza, except the 2009 H1N1 pandemic strain, hepatitis B, HPV, MMR, hepatitis A, meningococcal, and those vaccines that contain tetanus, and evaluate scientific evidence about the event-vaccine relationship. The IOM committee appointed to this task was not asked to assess the benefits or effectiveness of vaccines, but only the risk for specific adverse events. Using epidemiologic and mechanistic evidence, what I discussed earlier in the context of causation, the committee developed 158 causality conclusions and assigned each relationship between a vaccine and an adverse health problem to one of 4 categories of causation. The committee found that evidence convincingly supported a causal relationship between some vaccines and some adverse events, such as MMR, varicella zoster, influenza, hepatitis B, meningococcal, and tetanus-containing vaccines linked to anaphylaxis. But additionally, the evidence favored rejection of 5 vaccine adverse event relationships, including MMR vaccine and autism, inactivated influenza vaccine and asthma episodes, and others. However, for the majority of cases, 135 vaccine adverse event pairs, the evidence was inadequate to accept or reject a causal relationship. Overall, this committee concluded that few health problems are caused by or clearly associated with vaccines. Another common concern of parents is the use of a delayed or alternate schedule. They want facts and statistics and websites they can trust. Parents are concerned about the sheer number of vaccines we use, and it can be challenging to discuss all of the studies that support simultaneous vaccination or go into elaborate descriptions in textbooks that explain how the immune system is physiologically capable of responding to hundreds of thousands of antigens throughout life. The key is to share the important websites that can be trusted, such as those from CDC and FDA, to have sound scientific information and not talk down to parents, and to give unbiased, non-coercive, credible, non-judgmental information. On the issue of the childhood immunization schedule, the Department of Health and Human Services National Vaccine Program Office and CDC again looked to the Institute of Medicine, the IOM, and had them convene a committee on the assessment of studies of health outcomes related to the recommended childhood immunization schedule to conduct an independent evaluation of studying the safety of the entire schedule. This IOM report was released on January 16, 2013. In it, the committee expressed support for the childhood immunization schedule as a safe and effective tool to protect against vaccine-preventable diseases. The committee recommended using existing healthcare records data to continue to study the safety of vaccines. The committee also reconfirmed a finding of the National Vaccine Advisory Committee, or NVAC, that conducting a study which required some children to receive fewer vaccines than the recommended schedule, as would be needed for a randomized controlled trial, would be unethical. The current recommended immunization schedules, as published by CDC, the ACIP, the professional organizations, such as the AAP and AAFP, has flexibility and is the best way to optimize protection from vaccine-preventable disease at the times when children and adults are at highest risk and can respond to the vaccines. This concludes my presentation in today's program. Let me do one polling question. So the question is, can you tell me if Phase 4 post-vaccine licensure safety studies can evaluate rare reactions, monitor increases in known reactions and identify risk factors for those reactions, identify vaccine lots with increased rates of reactions, identify signals, that is, reports of adverse events more numerous than would be expected, any one of those or all of the above? So please take a second and vote. Well, it looks like well over 90% of you got the correct answer. It's all of the above. So thank you for your attention. Let me turn the microphone back over to Ms. Wielicki.
Thank you very much, Dr. Strickus. I'd like to direct our viewers to your screen where you see a pod that contains resources and other continuing education material, including the verification code for today's course. Please make a note of this verification code as it will not be given outside this presentation. Today's verification code is SAFE-615. This verification code applies to both the live program and the enduring program. I'll repeat the verification code, SAFE-615. I'll provide more details about continuing education at the end of the program. Now, we would like to review some of the questions we received during the program. Dr. Strickus, this is a common question that we get. What about the concerns some parents have that too many vaccines are given too early to infants and it is harmful?
Thank you, Ms. Wielicki. You know, from the moment babies are born, they're exposed to numerous bacteria and viruses on a daily basis. Eating food introduces new bacteria into the children's bodies. Numerous bacteria live in the mouth and nose, and an infant places his or her hands or objects in his or her mouth hundreds of times every hour, exposing the immune system to still more germs. When the child has a cold, he or she is exposed to up to 10 antigens, and if they have a strep throat, that's 25 or 50 antigens. Each vaccine in the childhood vaccination schedule has between 1 and 69 antigens. So a child who receives all the recommended vaccines in the current immunization schedule may be exposed to somewhat over 300 antigens through vaccination by the age of 2, which is far less than they're going to encounter in the course of an average week in their busy lives. Also, a 1994 report from the Institute of Medicine looking at adverse events back then stated in the face of these normal activities of children, it seems unlikely the number of separate antigens contained in childhood vaccines would represent an appreciable added burden on the immune system that would be a problem.
This is a follow-up question to that, Dr. Strickis. Many providers encounter patients who are creating their own vaccine schedule spacing. What do you recommend, or how do you recommend educating parents about this?
I think one can only do so much, and the types of points to be made are the ones I made now about the fact that the child is exposed to many antigens already. The vaccine schedule does not add many more, even if the child receives 4 or 5 vaccines at a single visit. Emphasize the safety of the vaccines that we've demonstrated over the years, and also that if you choose to exclude 1 or more vaccines from visit, then the child will not be protected against the disease in question for a longer period of time. For example, if you skip a diphtheria, tetanus, acellular pertussis vaccine dose, child needs at least 3 doses by 6 months of age to have some protection against DTaP, particularly if the mother did not receive pertussis-containing vaccine during her pregnancy. And so the child is at risk at the highest risk time for pertussis disease. So a missed opportunity or avoiding vaccination increases the risk the child may become ill. And unfortunately, pertussis has become more common, not less common, in the last 10 or 15 years, and is still a problem in many communities.
Thank you, Dr. Strickis. That's a great answer. Do we need to, another question that we frequently receive and are getting are, do we need to worry about someone receiving current antibiotic therapy? Can they be vaccinated?
Antibiotic receipt is really neither a contraindication nor a precaution, but there are some exceptions where it's considered a precaution to a few vaccines. This is considered an effectiveness issue because it may affect the replication of the live bacteria or virus. For example, somebody receiving an anti-influenza drug should withhold live attenuated influenza vaccine for at least 48 hours or 2 days after the medication is finished. If the live vaccine were given first, you should wait 2 weeks after the vaccine dose before you give anti-influenza medication unless the person is very seriously ill, and then you may have to revaccinate the person. If someone is receiving an anti-herpes virus medication, they should wait at least 24 hours or a day after that is finished before receiving varicella or zoster vaccine, if at all possible. Or, on the other hand, if varicella or zoster vaccine was given first, providers should wait 2 weeks before starting the anti-herpes virus medication unless that were urgent. And if you gave it sooner, you may have to repeat the varicella or zoster vaccination. If someone's receiving an antibiotic that would affect typhoid bacteria, if they're getting oral typhoid vaccine, they should wait until they finish the antibiotic at least 3 days to get the vaccine. If the vaccine were given first, we recommend 3-day period before you start the antimicrobial agent. So these are some examples of concerns around antibiotics, but in general, for inactivated vaccines, there is no concern about antibiotics and the concomitant administration of vaccines such as DTaP, inactivated influenza, or pneumococcal vaccines.
Thank you. Here's a question that we just received. Should a local reaction, for example, redness or swelling, be reported to VAERS?
That's an important issue because local reactions are so common. I think if there is nothing unusual in the mind of the practitioner or the patient seeing the reaction, because either the practitioner, the provider, or the patient or the parent can report the reaction to VAERS, then there's no harm in doing so. VAERS will accept all reports and make no judgment on them. But certainly if in your mind this is what you would expect to have seen, it's not really necessary. We're more concerned about things that are unusual, say a very large reaction, which sometimes happen after certain vaccines, such as pneumococcal polysaccharide vaccine, something out of the ordinary. However, if you're not certain that it could be a problem, better to report than not to report.
Thank you. Our next question is, are there concerns about breastfeeding an infant if mom receives a live vaccine?
In general, breastfeeding is neither a contraindication nor a precaution to routinely administered vaccines, either live or inactivated. And this applies whether the person to be vaccinated is the mother who's breastfeeding or the child who's receiving breast milk. Now, live rubella vaccine virus has been detected in breast milk after mom's been vaccinated, but not been detected in breastfeeding infants or any evidence of the infant had any adverse reaction either in the vaccinated mother or in the infant. Similarly, there's not concern about antibodies being transmitted to mom because they generally don't make antibodies that are transmitted. Now, there is one exception to this general statement that breastfeeding is not a problem, and that's yellow fever vaccine. There have been reports for people receiving yellow fever vaccine associated who are breastfeeding, complications in infants whose mothers were vaccinated. They're rare, but they have occurred, and therefore breastfeeding moms should be cautioned about receiving yellow fever vaccine and either cease breastfeeding or perhaps modify their travel schedule to a different time. But breastfeeding is a precaution if you're going to receive yellow fever vaccine. That's the only one I would acknowledge at this point.
Thank you. We have someone here who's wondering about contraindications. Is a recent history of pneumonia a contraindication, or do they need to wait an interval before administering pneumococcal vaccine?
No, if someone is no longer has a moderate to severe illness, and that's how you should think about pneumonia, is falling in that category of moderate to severe illness, where that's a precaution to vaccination, you might wait until they get better. If they're recovering, even if still in hospital, maybe the best time to give them pneumococcal vaccine, whichever vaccine they need, if that's what you're thinking about, or influenza vaccine, is at a time of discharge or perhaps the day before discharge. So if convalescence is fine, if they're at all significantly ill, one should wait until the illness has calmed down and eased.
And this question too goes along with the moderate to severe illness. How high a fever can a patient have and a vaccine still be administered?
You know, that's a question we receive commonly, and we don't specify a fever. It's got to do with the severity of the illness. Certainly some children in particular, more than adults, can tolerate high fevers, and they're scooting about and playing, and they really don't seem to be very ill at all with a fever of 102 or 103. And if in the judgment of the provider the child is otherwise doing well and you've identified the source of the problem, say a middle ear infection that you can treat with antibiotics, then you can give the appropriate vaccines. If there's any uncertainty about the source of the fever or the degree of illness, then one should hesitate and wait until the child is recovered from the febrile illness. But again, it is a judgment call, and we have not established a cutoff threshold for degree of fever at which you would or would not give a vaccine.
Thanks. We're getting a lot of questions today about contraindications, and we just received one about pregnancy. They want to know which vaccines are contraindicated in pregnancy.
I'm not going to give you a comprehensive list. It's available on our website. If you go to the ACIP recommendations, there's a list of vaccines contraindicated in pregnancy. But generally, live virus vaccines are generally contraindicated in pregnancy, such as MMR and varicella and zoster were a woman to be pregnant at an older age. And other vaccines, we have limited data. And therefore we've said either we don't have a recommendation or it's a precaution to vaccination, and these are vaccines such as inactivated polio, pneumococcal conjugate vaccine, and the HPV vaccines. So it's more about limited data, and if a person inadvertently receives one of those vaccines during pregnancy, we've not documented any real significant problems, but we would not say you should complete a series if this is part of a vaccine series such as HPV during pregnancy. One should wait and complete the series after the pregnancy. So please check our website, cdc.gov vaccines, and you can find the detailed recommendations, and I've just commented on some of them.
Well, thank you all for joining us. That's all the time we have for questions. So now I'll provide some continuing education credit information. Please go to the webpage seen on this screen, www.2a.cdc.gov/TCE online, to obtain credit. Today's live CE event course number is WC 2645-061516. I'll repeat that. WC 2645-061516. Please note that the 061516 denotes today's date and differentiates this presentation from others in the series. CE credit for the live course will expire on July 18, 2016. The course number for the Enduring Archive is WD 2645-061516. CE for the Enduring Archive is available until June 1st, 2018. You will also need a verification code, which is SAFE-615. This verification code applies to both the live program and the Enduring program. I'll repeat the verification code. SAFE-615. For help with the online system, available 8 a.m. to 4 p.m. Eastern Time, please dial 1-800-41-TRAIN. This corresponds to 1-800-418-7246, or you can email ce@cdc.gov. You can email immunization questions to us if you did not get to ask them today at nipinfo@cdc.gov, and we'll respond to those as quickly as possible. We also plan to post questions and answers from today's session at www.cdc.gov/vaccines/pink-book/pb1.asp. You can also call immunization questions at 1-800-CDC-INFO or 1-800-232-4636 at 8 a.m. to 8 p.m. Eastern Time, Monday through Friday. Additional resources you can use include the Pink Book and the website for the Pink Book, as shown on this slide at www.cdc.gov/vaccines/pinkbook/index.html. It's available online, or you can purchase a hard copy at the link for the Public Health Foundation Learning Resource Center. Our CDC vaccine homepage is cdc.gov/vaccines/default.htm. Our resource guide for healthcare personnel entitled CDC Immunization Resources for You and Your Patients is listed at www.cdc.gov/vaccines/ed/imz-resources.pdf. Follow us on Twitter for immunization news, information, and resources for private and public healthcare personnel. That's at CDC IZLearn on Twitter. That concludes our program. I want to thank Dr. Strickis for the presentation today and covering the topic in great detail and for answering the questions. Thank you very much and have a great day from Atlanta.